Hello, everyone, and welcome to our fourth EPIC call. It is the final call, and it's our first series. We will be repeating the 4 EPIC calls again with the second series starts on March 15th. Our focus on today's call is looking at incorporating prenatal breastfeeding education into practice. And we're very happy to welcome today Dr. Mandy Dornfield. Dr. Dornfield has been practicing family medicine for 10 years in Columbus, Indiana. She and her partners care for infants through adults and provide obstetric care. Dr. Dornfield helped found the Bartholomew County Breastfeeding Coalition, and she served as its chair for several years. She received her certification as a board-certified lactation consultant in 2011, and she offers breastfeeding medicine consults in her office. Dr. Dornfield currently serves as Chief of Staff at Columbus Regional Hospital, which is proudly a baby-friendly hospital. Mandy and her husband Dave have 3 kids, 10, 7, and 5, and are currently hosting their second exchange high school student, 16-year-old Sophie. And I'd like to add to this that in 2010, Dr. Dornfield was the recipient of our very first Breastfeeding Award of Excellent Physician of the Year for the work that she not only does in her community, in her practice, but the help and support that she gives around this state. So I'd like to, before I welcome Dr. Dornfield, I would like to show the objectives for today's call. I'm sorry, they're not coming up. Becky, do you have the objective slide there? Okay, thank you. This shows the objectives that we will achieve today. Recognizing the importance of breastfeeding, looking at evidence-based policy, common breastfeeding management, and identifying really what a breastfeeding-friendly medical practice looks like and how to make that happen. Next slide. All of the EPIC calls offer CMEs. And I would like to say that our speaker today has received no commercial support and conflict of interest. And so with that said, I would will bring up Dr. Dornfield's slides, and I'd like to introduce Dr. Mandy.
You might need it. There we go. Now you can hear me? Okay, great. Well, thank you very much. It's really humbling to be offered this opportunity. I know that Indiana is full of physicians who are passionate about breastfeeding and breastfeeding support. And what I'm doing isn't extra special, and a lot of you are probably doing similar things, but if we can share our ideas, hopefully we can make it better for everyone. Becky's going to help me with my slides. So next slide, Becky. Obviously, breastfeeding is important, and women make their breastfeeding or feeding decision earlier in their pregnancy, sometimes before they've even come to see us for the first time for their prenatal care. So it's very important that we begin talking about breastfeeding early on in the relationship. We know that if a physician recommends breastfeeding, a patient or a woman is much more likely to make that choice. Next slide. Barriers to breastfeeding education in the office. I think that this is the #1 barrier. Obstetric visits are notoriously short. We rely upon our nurses for a lot of you know, putting the data in, and we don't have much time. Next slide. I think a lot of us don't feel adequately prepared to educate. I know my breastfeeding education in med school and residency was pretty minimal. I know there have been times when I've secretly hoped that no one asks questions because they take time and we don't always know the answers. I think another barrier is that we don't want to make women feel guilty for their choice. But it's really important that we don't think of it as guilt, but as empowering a woman to make the right choice, or an educated choice, which is really the most important thing. Next slide. A woman cannot make an educated decision without being given evidence-based information. So I think of that as my job. That's my job when I educate about hypertension, weight loss, about infant care, and also about feeding choices, you know, the benefits and risks of each feeding type so that she can make the right decision for her. Obviously, not everyone will breastfeed. Sometimes barriers are just too hard to overcome. Women go back to work very soon at times. They may not have a place to express milk, even given our new laws. They may not have appropriate support at home. And, you know, we need to respect that. But maybe if she hears information in this pregnancy and the circumstances are different next time, she may make a different feeding decision next time. And I think that that's what we have to remember is we're planting those seeds, and maybe she'll make a choice next time if it's easier for her. Next slide. I see obstetric patients regularly, and my general opening question at their first visit is, have you considered breastfeeding? It allows me to know what they know about breastfeeding. A lot of patients say, yes, I'm planning on it if it works. And if they add that little, if it works, at the end, it tells me that they have some questions. And so it's an open-ended question, allows us to talk about that a little bit. I often say that breastfeeding is healthy and natural and the best thing for mom and baby, but it doesn't always come naturally for everyone. It's a practice skill. And so I tell them right up front that it can sometimes be a challenge to learn, but it's worth it in the end. So I think kind of hearing that message early on is important so that women, if they have some breastfeeding challenges, they don't feel like, well, I'm a failure, this isn't going to work. It's just part of the process. Anytime you learn a new skill, it's hard for mom, sometimes hard for baby. So sometimes not. But I think introducing that it's a skill we have to learn is important. I also ask them, do you have any family or friends who have breastfed? If they do, I encourage them to talk to those friends or family, reach out and start saying, hey, you know, can you help me with this? I'm considering doing it. If patients don't have any friends or family who breastfed, I know that they really need a support system because it's tough to know what's normal without having someone around you and coming beside you at home. Next slide. What if she says no? Like we talked about earlier, that's okay. But I do want to know why she's decided not to breastfeed. I think sometimes there are a lot of misconceptions. Well, I don't have time. I have to go back to work in 3 weeks. But it's important for them to know it's not all or nothing. She and the baby could really get a lot of benefit, bonding, antibodies, nutrition in 1, 2, or 3 weeks. And I think it's important to celebrate that if she chooses to breastfeed for 2 weeks and then go back to work, or 2 weeks and then switch to formula, that's a win, that's something. And I think trying to be positive about that instead of thinking of it as a failure is really important too. So, you know, if a mom says, well, I have to go back in 3 weeks, I'd like to breastfeed, but I just can't, I say, well, you know, you could breastfeed for 3 weeks, and we talk about the benefits of that. And, you know, opening the door to that education throughout the pregnancy is important. Next slide. A lot of women say, well, you know, I'm not going to breastfeed because I smoke. I'm going back to work. I don't want my breasts to hurt. I've heard it's hard. I've had a bad experience in the past. I take an antidepressant. It's important to know what the reason is, because maybe it's not a true contraindication of breastfeeding. Smoking is not a contraindication of breastfeeding. Most medications are not a contraindication of breastfeeding. And it's really important to empower the mom to know that. Of course, we don't want her to smoke around the baby, but that's a discussion to have. It's not a contraindication. The other things, certainly, you know, your breast could hurt. It can be hard, but I think having the discussion and talking about that it shouldn't hurt, there's lactation consultants and there's people who come along beside you who want to help you so it doesn't hurt. I think that's important for them to know so they can make an educated decision. Next slide. One thing, if we're talking about breastfeeding, I think it's really important to think about the messages we're sending, even unspoken. Hanging up posters in the office that are sponsored by formula companies, giving out formula bags, giving out marketing materials. Those are all marketing. It might be subtle, but it's there, and patients see that as a cue from you that, well, if my doctor says it's okay, my doctor is advertising it, it must be okay. And, you know, formula isn't evil, but we all know that breastfeeding is the best, and we want patients to get that consistent message. When patients hear inconsistent messages, it's really hard for them to know what's right. So if you give out formula, keep it in a closet, don't keep it out. The best advice is to not give it out. In my practice, we gave away formula for years. We kept it under the baby scale. If moms needed formula, we'd hand it out. And about 5 years ago, we said, why? And some doctors worried there'd be a problem if we stopped, but we just stopped. It was simple. And we haven't had formula for 5 years. No one's given us a question about it. You know, if you see a baby in the office who's having trouble breastfeeding and you think they need to be supplemented, you can go buy the formula just as easy as it being given out in your office. And there certainly are situations where babies need a supplement. But we haven't missed the formula or the marketing, and neither have our patients. Next slide. Of course, part of your prenatal exam is a breast exam. I think that's really important because sometimes moms are self-conscious about their breasts, their physical structure, and they've already decided they can't breastfeed because of how they're made. For example, inverted nipples. That is not a reason that you can't breastfeed. It might be a challenge, but it's important to correct those false impressions, those wives' tales, things that their friends have told them that may be incorrect. It's also important to identify challenges ahead of time. We don't want to set up women for failure, but we want to get them set up with their cheerleaders and their lactation consultants as soon as possible. Next slide. So, for example, PCOS is definitely an increased risk of poor milk supply. If you've had a history of a breast reduction, it's important to know how that was done and have a plan in place for breastfeeding. Also, to set up reasonable expectations. She may get a full milk supply, but she may not. And if she doesn't, how can she supplement at the breast? Talking about those things ahead of time may help prevent her from feeling like a failure when she's trying to learn a new skill. And I will say that I struggle with getting lactation visits covered. We don't have great outpatient lactation services here in Columbus. We do have some great support groups, and so I try to refer ahead of time to those support groups who I know have good lactation educated folks in them, so that she can be educated and she can meet the cheerleaders that she will need when the time comes. It is really hard when your baby's 2 days old to find someone to call if you haven't already made those relationships. So sending them to the La Leche League if you have a good active La Leche League or a breastfeeding support group. Bloomington was way ahead of the game and had Bloomington area birth services, BABS, Go BABS, and they modeled for us a outpatient lactation drop-in support group that they called Nurse and Chat, and we modeled ours after theirs. And it isn't technically associated with our hospital directly, but that's a support group that's free and has lactation consultants available too. So getting those things, referrals made before mom has the baby, can be really helpful. Next slide. I think it's important to note the feeding decision in a sticky note or the problem list. You know, you may or may not be seeing the patient next time. We don't want to hammer home something that we've already talked about. But it helps me to know how to tailor my discussion at the subsequent visits. So if she definitely wants to breastfeed, I want to be sure she signed up for a breastfeeding class. We might discuss a pump if needed. We might, at 36 weeks, I try to be sure to discuss any concerns she may have. I have a lending library, and this is one of the books, Dr. Jen's Guide to Breastfeeding. I have about 5 copies of it. I lend that out to moms who are interested. Some moms are into reading, some aren't, but I think it does a really good job of why it's important to persevere and keep trying. Even some breastfeeding is better than none. And it goes into the science of that a little bit for the moms who are interested in that. Next slide. If she's chosen not to breastfeed, I think that's also important to make a note. You know, sometimes it's just totally inappropriate to keep talking about breastfeeding if she's made her decision. Maybe she's tried it 3 times, she's not going to do it, and it's disrespectful to continue talking about it. And I respect that too. Sometimes she's open to further discussion. Next slide. I think it's important to know what your community has for outpatient services. Do your birthing classes include breastfeeding class? Here in Columbus, we have a 4-part birthing class, and one of those parts is a full 2-hour breastfeeding class. Some moms just can't get to a class because of transportation or maybe she's working. So it's important to have some other resources for her. In Indiana, we're really lucky to have great lactation classes through WIC that are free, so that's a possibility for some moms. Internet resources are actually really important now. There are lots of social media support groups, and there have been some good studies showing that they're very effective for moms. In Indiana, or in Columbus, we have a group called Columbus, Indiana Nursing Mothers. It is a closed group. They have to request to be a part of it so that they can keep it, you know, no creeps on there. But I know that that's a tremendous source of support to a lot of our moms here in Columbus. And there are others around the state too. Next slide. Excuse me. At our 28-week visit, I try to use that as my big education visit. I know she's going to be getting her diabetes screen at that visit. That's how we do it here in our office. A lot of times she's going to be around for an hour, so I try to take extra time at that visit. I talk about rooming in. In our hospital, we have rooming in, 24-hour rooming in. We are baby friendly. It's really important that moms don't feel like they're not getting the care they need. So I think it's important to choose our language well. I try to use this language. I try to say, unless your baby is sick or needs special care, your baby will be staying with you in your room during your hospital stay. And we here in Columbus try to say, it is important to have a helper spend the night with you, someone who can help you with the care of your infant. And I always say, no one was meant to take care of a baby alone. We all need a partner. And so that allows the mom to say, you know what, maybe it's not going to be my husband, maybe he's going to stay home with our other kids, maybe that helper is going to be my mom or my sister or a friend. And it's okay if it's not a male partner, but it's important that she not be alone, because at home it's important that she not be alone. No one can do that. It's exhausting to be caring for an infant who's nursing and needing their diaper changed every 1.5 to 2 hours. I found that language works really well. I've not found anyone feels that we're abandoning them. We also try to explain that our nurses will teach you how to care for your baby in your room. Again, so they don't feel like the nurses aren't there for them, but we try to explain that we're happy to help the mom in her room to learn how to care for her baby. And then we go over breastfeeding, any breastfeeding questions too. Next slide. I apologize for my voice, I'm losing it. I also use this visit to discuss skin to skin. I explain what it is, that it's the best for mom and baby. It helps with bonding, it helps with temperature regulation, helps with adjustment to the outside the womb. And it's standard for all moms and babies. It's not just for breastfed moms and babies. And once in a while, a baby will self-latch and a mom may choose to breastfeed, or maybe she breastfeeds, you know, for the 2 days she's in the hospital. But that's a win if that's something that she's able to try that she hadn't thought about. But it's not just for breastfeeding. There's a lot of really important bonding that goes on with skin to skin. When we first started doing skin to skin, we had a few patients worried about the ick factor. But you know, I explained at the visit that we dry the baby, We put the baby skin to skin. The nurses are right there to evaluate the baby right there on her chest. And that puts moms at ease. And I really haven't had anyone decline it since we started explaining what it's for. Next slide. One thing that I've started doing recently, which is fairly new for me, is talking about hand expression before the birth of the baby. It is safe in low-risk women. You know, of course, a lot of women tandem nurse and breastfeed during their pregnancy. If a woman has a history of preterm labor, I wouldn't recommend it. But number one, it allows a woman to get comfortable with the skill. For some women, they've never touched their breast in that way. It is a learned skill. It can help them build confidence if there is colostrum there. Some women won't have much, but sometimes visualizing that is helpful. Some women have a lot of colostrum, and you know, if she's able to express enough, even 1 or 2 teaspoons, she could put it in a sterile syringe and freeze it and bring it to the hospital with her and use it, you know, as supplementation if needed. So we try to talk a little bit about that at around 36 weeks if she's comfortable. Certainly not necessary. Next slide. A lot of you may be aware of Dr. Milk. It's a closed Facebook page for physicians only. I think it was started in Arizona as a breastfeeding support group for physicians, but it is also kind of morphed into a forum for physicians interested in breastfeeding. I did pose the question on Dr. Milk, hey, what would you want to say to these doctors, smart doctors who are interested in prenatal breastfeeding education? And they gave me some of their ideas. Next slide. One doctor said that they have trimester-specific handouts made out to give at each visit. So if you don't have a lot of time to talk about it, you can just hand them the paper at each visit. Next slide. Next slide. I thought this was interesting. One doctor pointed out that a lot of women come in for OB triage appointments and spend several hours sitting in their OB triage room. And you can have the handouts available there so that she can read and be educated while she's kind of hanging out in OB triage for UTI or whatever. Next slide. I think the most important thing I'd want to emphasize in this talk is that it's so important that we give accurate information. A lot of times we just don't know the answer. We aren't educated on everything there is. And it's much more important to say I don't know than to give the wrong or not evidence-based answer. So a couple common issues that come up are, is it safe to breastfeed a toddler or infant while pregnant? Yes. And after the new baby's born, the newborn nurses first, then the older child. The exception to that would be a history of preterm labor. It's important to know that there are very, very few medications that are contraindicated in breastfeeding. LactMed is a free app from the National Institute of Health. And I think everyone should own a copy of Medications in Mother's Milk. It's wonderful. And we keep a copy of that in our office. Our Breastfeeding Coalition has purchased a copy of that for every single floor in the hospital as well. Next slide. I think it's really important to remember that pumping and dumping is not benign. And if you're here listening to this talk, I don't need to tell you that. You know that. CT diet does not require pumping and dumping. And if there's ever a question, the most fabulous resource is at our fingertips. The Infant Risk Center is in Texas. www.infantrisk.com, and their phone number is listed there. Any medicine, even if there's no published data, a lot of times they have done pharmacokinetics on the medication and are able to tell you the likelihood of the medicine getting into breast milk and the effect on the baby, even if it's new. So they're a great resource. Next slide. Other resources, drmilk.org also has a website, and there are lots of good resources on there for physicians who want to educate patients on breastfeeding. The Academy of Breastfeeding Medicine, I'm sure you all know, has many, many protocols, including a breastfeeding-friendly physician office protocol. It's outstanding. We talked briefly about internet resources for education, and Stanford has lots of good educational videos. I mentioned that one because you know that it's a good source. The website is listed here. And they have videos on hand expression, hands-on pumping, evaluating latch. And you can just tell moms this website and let them go and watch, on their own to get education if they're not able to get to a breastfeeding class. And that's the end of my formal presentation. Thank you so much for coming, and I'm happy to take questions.
Dr. Dornfield, I have a question while we wait to see if any questions come in. I was wondering if you could speak to how having a baby-friendly hospital in your community has helped you and the work that you're doing with breastfeeding in your practice. You touched on this, but could you elaborate a little more?
Yeah, I think it's really interesting. Anyone who's working on the baby-friendly process knows there's a lot of growing pains. But now that the protocols are in place, we've normalized a lot of the things that before were new or difficult. So skin to skin, it is what it is. We know that there's evidence that is the best thing for mom and baby. So, I do think it's important to introduce it before they get to the hospital. They need to understand what we're doing. And so I think that it's important, the onus does lie on me to make sure they know why we're going to be doing this at their delivery. But it gives us the opportunity to talk about it and the importance. Again, rooming in, the key to rooming in successfully and having a good experience in your hospital, in my opinion, is really good messaging ahead of time. We're not abandoning you and your baby. Your baby's best with you. We want you to bring a helper. You aren't supposed to do this alone. And in fact, there are some moms and babies who the mom really needs a break and needs the baby to go to the nursery. That happens sometimes. Twins, for example, or maybe she doesn't have a helper. A mom cannot do it alone. But educating ahead of time, I think, is the key for us to be successful with rooming in. And we consistently have 90% rooming in rates. Our breastfeeding rates have improved tremendously. Initiation rates are up to about 90% pretty much all the time. We struggle a lot with continuation rates. And I think that, the other side of having a successful baby-friendly program is that we have more moms who need more help as outpatients. And so right now we're having those growing pains of how can we build our outpatient lactation services to support them.
Yeah, this is Becky. I wanted to go ahead and encourage everyone, if you've got a question on the bottom, if you roll your mouse over the icons at the bottom of your screen, there's a Q&A, and go ahead and submit questions there if you have any questions.
I see a question that was written in the chat. Have you heard, Dr. Dornfield, about the service called Mother to Baby that's similar to infant risk? Do you know of that yet? It's new to our state.
I don't know about Mother to Baby. So,
okay.
Yeah.
So I guess it's a grant that is in different parts of the country, and there's recently been a grant to, I think, the IU School of Medicine that has started a Mother to Baby, I guess, chapter in our state, and they actually do something very similar to infant risk. So just to get that on your radar.
Yeah, that's
I'll send you some information about it.
Yeah.
So that's a new thing we just learned about. Someone in my office has a question. They would like to know if you could give ideas for specific educational materials that you might be providing to your patients prenatally.
Interesting, when I posted this question on Dr. Milk, a lot of people said, we want to create these trimester-specific handouts. A lot of people said they're working on it, but no one had a formal location where they downloaded them. They were just making them themselves. But I think that, if we could share that, if one of those physicians does come up with some great handouts, sharing, I think, is the key. But I don't have any trimester-specific handouts that I use right now.
Okay, thank you.
I would say, one, we're talking about resources for outpatient lactation services for the physicians on the line who aren't aware. I think obviously a lactation consult in person is the best, but there are some locations that just don't have that availability, and there is a service now called Milk on Tap, and it is a virtual lactation consult via a webcam, flat cash pay price, by number of minutes. I think it's $40 for 25 minutes or $75, I think, for an hour. I don't know. Don't quote me on that. But it is out there, and that's those are true lactation consultants, and it's an option for people who don't have access to lactation content.
I did not know about that. So that was very helpful to know that's out there as a resource.
Yeah.
Very
Yeah,
good.
I've got a question. I've got two girls. They're 10 and 5 now. And I was not successful either time with breastfeeding. I did try, and ultimately had to give it up both times. I had C-sections, so I had some pain. Initially, I was worried that some of the drugs that I was taking for pain would inhibit my ability to make milk. I don't know that was the case so much, but I think both of my girls had reflux. And I was interpreting their screams of reflux, and I do mean screams, of that they weren't getting enough to eat.
Aw. Yeah.
We supplemented, and then I quit breastfeeding.
Yeah. Yeah, and that's a really good example. I think that you should be celebrated that you tried it, and there comes a point where you have to do what your baby needs. And at the time, you didn't have the education, or you weren't given the right diagnosis, possibly not. We don't really know now. And so you do what you do. Feed the baby, number one. Feed the baby, number one. I will never ever make someone feel guilty for feeding their baby. And I think it's unfortunate that people who are involved in lactation medicine, sometimes they get this false reputation for being breastfeeding Nazis. And my passion is evidence-based medicine to help the moms and babies, and we do our best, and you did your best. But yes, reflux can definitely cause discomfort for babies.
I have a question that's been put on the screen. Do you work with a lot of women who smoke, and what do you tell them?
Yeah, we do have women who smoke. I think that Bartholomew County has the highest tobacco use rates in the state, unfortunately. And what I tell them is smoking increases the risk of SIDS. Do not smoke around the baby. Smoke outside and change your clothes. But smoking, having smoked a cigarette, and it is not a reason not to breastfeed the baby. If you think about it, those are the babies who really need the breast milk and decrease risk of SIDS with breastfeeding. So there are benefits that those babies can get whose moms may have breastfed or who have smoked. Excuse me. So I do encourage them to breastfeed, and that's what the evidence suggests as well. But I do tell them to smoke outside and change their clothes. And obviously I tell them if they can cut back, they should. If they can stop, they should. Even eliminating 1 or 2 cigarettes a day is better. We try to go with that, because I think sometimes people think it's all or nothing. And if they can decrease, that's better than continuing to smoke a pack a day.
Yeah, here at the Indiana Rural Health Association, we hear stories around the state and around the country about opioid deaths a lot. What kind of advice do you give mothers who are users? So
if a mom is postpartum from a C-section, for example, and needs hydrocodone for pain control for a limited amount of time, we generally think that is fine. Some of that can get to the baby, especially early on, but don't forget the volume is very, very small early on. But we do, watch for sedation and things like that. But if a mom is an abuser, no, we do not recommend breastfeeding. Absolutely not.
Mm-hmm. We have another question that's come in, and we're just giving you a lot of questions today. How do you, in your practice, and involve dads in the education that you give?
That's a great question. I'd love to hear what other people say about that too. We encourage the dads to go to the breastfeeding class. I think the fact that our breastfeeding class is part of the birthing classes helps with that, because the dads are already going to the birthing classes. And so it's just another class that they go to. I think it's important that they know what this entails. It's like I always say, it's healthy, it's the best, but it's tough in the first couple of weeks, and that mama is going to require a lot of support in the beginning from dad, and a lot of cheerleading and understanding from him. So we just encourage them to go to the breastfeeding class, and obviously, if dad's there in the room when we talk about breastfeeding, sometimes he'll speak up and have an opinion. I've had dads say, absolutely, she's breastfeeding, she doesn't have a choice. I've had dads say, oh, that sounds kind of weird, and then we talk about that. But I think it's important that dad's on board.
Mm-hmm. You talked a lot about some of the misconceptions where women may think they can't breastfeed, like antidepressants or smoking. But could you touch a little bit more on some of the common questions that people ask you just about lifestyle or attitudes or beliefs that, that you're commonly seeing?
Yeah. Well, I think a common excuse or concern for moms is, my diet isn't good enough. I eat junk food. Baby will take what baby needs. Mom's breast milk is always best, no matter how bad her diet is. So I think it's important to reassure her she doesn't have to eat impeccably. I think some women worry, well, I need to eat, salads every day and only grilled chicken for dinner and never ever have a soda pop, and never ever have a coffee. That's not true. As long as your diet isn't, I guess, heroin, if you're eating a diet that most of us eat, your breast milk will be fine. And I think that's important to reassure the mom that it's amazing what our body can do. The body makes the perfect blend of breast milk from whatever we're feeding ourselves. So that's one thing that I hear commonly. I have heard women say they don't want to breastfeed because they can't drink a cup of coffee. A cup of coffee is generally fine. A soda is generally fine. I wouldn't recommend Polar Pops, but we know women do it. And breastfeeding after drinking a Polar Pop is still better than not breastfeeding. I think that other questions, usually it surrounds medicine. A lot of women are just think they can't breastfeed because they're on medicines, and sometimes it's the most benign medicines like thyroid medicine or certain blood pressure medicines. Most of them are compatible, and if they're not, a lot of times we can find medicines that are compatible.
If the baby is having a lot of gas, what kind of changes to the mother's diet do you recommend?
Well, it may or may not be related to the mother's diet. If the baby's having a lot of gas, I do say think about the foods that can cause gas in big people, and they can cause gas in little people. So onions, rare meats, beans, broccoli, raw broccoli, things like that. But it may have nothing to do with her diet, and you don't want mom to feel like she has to go on a total elimination diet. Sometimes babies just have gas, whether they're formula fed, breastfed, it's not going to make a difference. So.
We have a question that has come in, and this question's kind of near and dear to my heart because we've been doing work at our organization working with teen moms to breastfeed around the state. And this question is asking, do you see young moms, teen moms in your practice, and have you tailored any education or find that their issues are a little more unique, or what can you describe about that?
Yeah.
Or tell us about that.
We have teen moms in our community, but our practice, for some reason, doesn't get a lot of them. I have worked with the Breastfeeding Coalition We've intervened on behalf of some teen moms who are having trouble pumping at the high schools. And so we've talked to the nurse. Well, all three of our high schools now, we have a Columbus North, Columbus East, and New Tech was a kind of an alternative high school. All three of them have plans in place for breastfeeding moms now. So I don't think that's as much of an issue as it used to be. But I think it's tough for those young ladies because they're supposed to be full-time students. They're young. They're supposed to be doing their homework. They're supposed to be a full-time mom. It's really tough. So I think for them especially, celebrating anything that they're able to do as far as breastfeeding and making them feel good about themselves and feel proud of whatever it was that they were able to give their baby. 2 months, great. That's amazing. 3 months, awesome. But I really try to celebrate what they were able to do because it's very stressful for those moms.
I have a question. One of the things that we're trying really hard in communities to do is to connect people up. So you talked a lot about referrals. As I have traveled in communities around the state and gotten the opportunity to speak with physicians and ask them, what is the number one thing we can do for you? And they're like, help us with referrals, or have our coalition make us a referral sheet, or help us connect with what's out there in the community. I know that you headed up the Breastfeeding Coalition for a number of years, and so that allowed you to make those connections in the community. But for somebody that might be on the call today that doesn't, that would like some suggestions on some ways to connect with what's out there, what would you recommend? Like, what kinds of things come to mind?
Yeah. So are we talking about connecting with lactation consultants and support groups?
Mm-hmm.
Yeah.
Yep.
Well, if your community has a coalition, they will know where those lactation consultants and support groups are, and they would be more than happy to give you their information. And in fact, as a physician, I don't want to refer a patient to someone who I don't know. I don't know if they're going to practice evidence-based medicine. And so, if you even wanted to go to one of those meetings and meet the people, I think that that's really helpful. But they'll come to you if you ask, and the coalition's a great resource for that. Your hospital obviously can be a resource. In some communities, the hospital is the breastfeeding support group and resource. In some communities, it's not. So I think that's another way. ILCA, Indiana, is the lactation consultants group, but not all lactation consultants are a member of ILCA, but you can go to ILCA and see what lactation consultants are around. I find the bigger trouble is not finding lactation consultants, but getting it covered. I know insurance is supposed to pay for it now with the Affordability Act, but we have not found that necessarily to be the case in our community. We've had a lot of trouble with getting lactation consults for outpatients covered. So one thing I'm doing is SciHo is based here in Columbus, Indiana. That's an insurance company, and that's low-hanging fruit. So I'm in discussions with them, talking about the importance of covering lactation consults, and I have a meeting set up with them the end of March to talk about maybe them expanding their benefits to include lactation consults.
Have you had any, another question came through talking about lactation consultants, the breast pumps, if a woman is not able to or has trouble self-expressing, decides to use a pump. Do you find insurance, will they ever pay for that pump, the cost of that pump?
Yeah, so with the Affordability Act, I'm sure most of the physicians know that coverage for breast pumps was included in that. It's interesting how insurance companies have interpreted that. At first, they were like, sure, breast pumps if needed. So every single patient was getting a prescription for an electric breast pump, which is a wonderful benefit, but it was probably around $300. So I think the insurance companies have gotten wise to that. Some are now requiring trial of a hand pump first. It's good and bad. I want to be a good steward of our resources, but for a mom who's having a supply issue for a newborn in the hospital, or a latch issue, or maybe she has a baby in the NICU, a hand pump isn't going to do it. She needs an electric pump. And so sometimes that's that's a little, that can delay things, unfortunately, and be a barrier. But for a while, it was pretty much a free-for-all, and we were seeing that everyone was getting an electric pump, but now we're seeing that we're needing to jump through some hoops. At least in Columbus, that's what we're seeing with benefits. I don't know what everyone else is seeing around the country. If a woman has WIC and she's going back to work, she can get a pump there, but usually not unless she has a need to, and she's going to be separated from her baby. One thing, a partnership that we started in the last few months here in Columbus was more of a partnership with WIC. I know that Bloomington has been doing this in Monroe County for a little while, but a WIC peer counselor comes in to our hospital 5 days a week for patients who have agreed to allow that. She is able to see the patients who are WIC clients and meet with them, schedule a follow-up appointment, and if she needs a pump, begin that process so it's not as delayed. And I think that's a wonderful thing. I think we need to be careful we're not stepping on toes, but in general, I think it just facilitates outpatient follow-up and it introduces patients to who WIC is, puts a face with it, so it doesn't feel as scary.
Yeah, I know there's certain, I won't name any companies, but certain companies that make the pumps are very restrictive, even if you're trying to purchase new equipment for a pump that you've already purchased, and they want registries and, you know, this kind of stuff. Yeah. Are there any resources where women who are finished with pumps can turn them in and they can be, you know, get all new pumps and get cleaned and sterilized and then be reused for another mom?
Well, that's a good question. Certain pumps are single user pumps, and some of the newer, like Hygeas, I believe, are multi-user pumps. So you guys may know the resource, Tina, you may as well. I just saw something kind of on Facebook, I think, about you can turn in your pump when you're done and maybe it could be refurbished and reused, but I wasn't aware of it before then. Certainly the single user pumps, I'm not sure you could do that because it's not a closed system. But the multi-user pumps, yeah, there is, I'm not sure if it's just for charity or if there is something out there now. Mm-hmm. Tina, do you know what that resource is?
Yeah, I've heard they'll take it back and refurb, and then it goes to people in need. I don't know if it's in this country, but yeah, that's a good new addition. I don't think we have any other questions. I last call for any questions. I love that you brought up that WIC is such a great resource, and I know personally that a lot of WIC programs around the states are really reaching out to doctors' offices and, you know, wanting to be seen as a resource. So, you know, in communities where physicians are just really wondering, you know, the WIC is also a good place to start. So. Just a reminder about that. Well, I loved the information today. I thank you very, very much for being our resident expert physician. And I invite people to tune in for our first call of EPIC Round 2, or 2.0, I should say. And we will have Dr. Emily Scott, who is a pediatrician from Memorial Hospital. And she is basically going to do an hour. There will be no questions. It will just be complete information, 60 minutes of everything you need to know. And that will be at 12 noon on March 15th. And thank you again, Dr. Dornfield.
Thank you for having me. It's my pleasure.
Mm-hmm. Bye, everyone.